Good evening, everyone. I hope you're doing fine, and I hope your CVP preparations are undergoing. And I hope you guys aren't that much cramped because I know I do recognize that you do have a an exam before the week-long vacation. So I hope you'll do well, and I trust you guys. And inshallah, with these PAL series, you're gonna do even better. So without further ado, let me introduce myself again because of the technical issue that happened. So I'm Ahmad Al Jandali. I'm second year in medical program here in Al Faisal. And today, inshallah, I'll be your tutor for a very peculiar lecture, which is a ventilation perfusion mismatch, and another one, which is control of breathing. Inshallah, everything in this lecture or slides is inclusive of the two lectures. I did make sure to include everything. Please note that I had to include everything for completeness sake, even though that not everything is going to be asked on, or it's not everything is high yield. I mean, I'll be sure to tell you what's more high yield in my opinion, but I'm just doing my best to predict, you know. No one can guess 100% right. So if you have time, please do study everything. And without further ado, this is my email. You can shoot me an email whenever you want if you have any concerns or questions, either inside this lecture, outside this lecture. I'm open to any questions and I'd be very happy to help. By the way, if you have any questions during this lecture or this session, please interrupt me and ask your question. Our goal here today is to make you all leave understanding everything and somewhat having a good grasp of it. Okay. Um, so let's just explain what we're going to talk about in order, just to make you feel a bit less lost. So the first thing we're going to explain is perfusion ventilation mismatch, which is denoted as VQ mismatch. Then we're going to move into something that is called alveolar arterial difference, which is somewhat related to the first concept, but it's just a more specialized one. But then we're going to explore how the body reacts to such changes and how it maintains the balance and equilibrium. Later, we're going to learn how to tackle a clinical question using differential diagnosis. It's very simple. Don't get overwhelmed. I have a good plan for you guys. Okay. Finally, we're just going to discuss how our bodies react to different stimuli in the regulation of breathing, because the regulation of breathing is what keeps us alive, and it's a very important mechanism. Uh, During the course of our lecture today, there are going to be questions that are inspired or even copy paste from the past files. Um, so make sure you understand those because they tackle the core concepts and they're pretty much high yield because they came in the past. Okay. Do we have any questions before we start? No. Okay. Um, so the first thing on our agenda today is the VQ mismatch. But I want someone here to kindly tell me what we see in front of us. Any chat? Okay, exactly. This is Cristiano Ronaldo, one of the, okay, actually the best human athlete in Earth. And why did I put it in a medical lecture? It's because it's related to our lecture. So, what makes someone like him a very good athlete, and what differentiates him from like a normal person? A good athlete has good cardiovascular pulmonary fitness, okay? Which means that their lungs are working perfect and their heart is working perfect. And a very huge aspect of that is VQ mismatch and how the body reacts to it. So a good athlete with good fitness is going to have a very perfect repair system for the VQ mismatches that happens. Okay, so this is a very important figure. Why? Because this actually describes a lot of stuff, but just let's take it step by step. So this is perfusion distribution along the lung. And if we were to notice that these arrows are not accurate, but they just mirror some true values, okay? Just take the whole concept. So here we have a small arrow, which means there is a very small blood there in the top of the lung. And as we go down, the blood or perfusion increases. Perfusion is how much blood goes to a certain area in the body. So as you can see, the arrows get larger and larger. And why is that? A very simple high school answer would be because blood is mostly composed of water and liquid, so it's heavy relatively, right? And gravity affects the blood distribution, and that's why we end up with higher blood in the base of the lung than the top of the lung. I hope that's clear. So now we can conclude that the base of the lung is more perfused with blood generally than the top. Now, what about ventilation? Ventilation is how much air reaches the alveoli. Okay? Now you will tell me, why is there also an increasing gradient from up to bottom, even though air is very thin? Which is very simple answer. Remember how we know about compliance and alveolar compliance? Okay, so imagine you have a balloon, okay, and this balloon you have it attached to something that stretches it down, something very heavy. It will be stretched, right? And this is somewhat the same concept, okay, because the higher alveoli in the top of the lung have um, have been stretched by the weight of the other alveoli in the rest of the lung. As we can see, let's imagine this alveoli. This is the weight of the bottom of the lung, okay? So they're already pretty stretched. And I hope this is clear because this tells us why it's less compliant. And so therefore, because of the less compliance in the upper alveoli, it doesn't get so much distension. Therefore, it doesn't get so much air. And the base of the lung has more compliance. The alveoli there are more compliant, and therefore they have somewhat larger ventilation or air that reaches them. Now, please note that these two gradients aren't identical. So for example, here we have a bigger arrow in ventilation than that we have in perfusion. Did you catch on it? Because in the base of the lung, we have a smaller arrow relative to the perfusion. And if you understand what I just said, you basically solved the lecture. Ladies and gentlemen, this is what ventilation perfusion mismatch is. In other words, let's take this one more step. Just to recap, gravity means more blood pools at the bottom of the lung. The upper alveoli are less compliant because of the stretching from the rest of the base of the lung. And VQ, this is the new thing, is highest at the peak and decreases towards the base. Why? Because, as we said, here we have a larger ventilation than we have perfusion, which is Q. Perfusion is Q. So therefore, we have a high VQ ratio. But here, downstairs, or in the base of the lungs, we have high perfusion and less. So we have high perfusion and less ventilation, which means if we know basic math, we get results with a decreased um, VQ ratio. Now, I wouldn't be very confidently telling you which one is better because it's more complicated, but follow along, okay? Um, so again, V is the ventilation, which means how much oxygen reaches the lungs. Q is the perfusion of how much blood comes to the lungs, and this carries the oxygen away from the alveoli. So we have a new definition that is called average VQ ratio. Now, the average VQ ratio is our set point. Okay, why? Because it's the ratio of total alveolar ventilation throughout the lung per total lung perfusion over the lung. So total ventilation over total um, perfusion gives us the average VQ ratio. And remember when I told you that this is our set point? Yes, because let's see at this here. Let's take our attention down. In the top of the lungs, we have hyperventilated areas, which means that we have more air than that we have blood, relatively. So again, let's do basic math. Higher V, lower Q or lower perfusion gives us a very high VQ ratio, which is greater than the average ratio that we have, like from the total ventilation perfusion. Okay. In the middle of the lung, we start reaching areas where it's normal ventilated. It's kind of not mismatched. It's kind of equal how much we get blood and how much we get air. So a VQ is the average ratio. It's equal. It's very equal to that total over the total. Because why? There's normal um, distribution here in normal ventilated areas. Now, what does hypoventilated areas mean? It means that there is more blood than there is air. So again, let's do simple math. Q is in the denominator and V is up. So if we have decreased ventilation, increased perfusion, we reach a lower or smaller VQ ratio. And this is what we have here. I hope you guys were able to get the conclusion with me. So if you guys don't understand what VQ is yet, I have a very good metaphor. Imagine a bus terminal, okay? Now we have a bus terminal. Let me just zoom in here. Okay, so we have a bus terminal and we have buses that come. Okay, these are buses that take these passengers from this bus terminal. Now, if we have 200 people in this bus terminal and each bus can take 20 people, what is the most efficient transportation method? Having 10 buses to be able to hold 200 people, right? Okay, so keep this in mind because this is going to be relevant here. Remember the bus metaphor? What if we have 200 people, but only, for example, two buses? It means that there is more people than there are buses that can take them. So we have a build-up of people. And if you are if you're catching up with me, you would recognize that the people symbolize oxygen in the infused air or like the ventilating air. If we have high ventilation or high amount of oxygen in the alveoli, high air, and low perfusion, which is low buses, we cause a buildup and inefficient transportation. Let's take the opposite. We have 20 buses for 50 people. Each bus will have only 2 or 3 passengers. Is that efficient? Maybe it's not the best efficiency, but it takes them. I hope this didn't take you in a different trajectory rather than it's just to simplify. So remember the high people, low buses thing? Here is what here is the example. So ventilation perfusion mismatch is always somewhere in between a spectrum. The spectrum from here to here. So let's take the first extreme case, which is an alveolar dead space. We know that alveolar dead space is a place where there is no gas exchange. Okay. This place is always ventilated, right? Definitely. But it is not perfused. So what do we do if we have, for example, 100 over 0? In math, that means it's infinity. And this is what we're trying to say here. If we have so high ventilation and zero, literally zero perfusion as in alveolar dead space, it means that the VQ ratio is on infinity. Again, this is ventilated but not perfused. The second, and in the middle between this extreme value and the normal ventilated, which is the best case, we have hyperventilated areas, okay, which have high VQ ratio. Okay, so the different part of the spectrum, we have the right to left shunt. Don't worry about the meaning for now because I'm going to explain what right to left shunt is, but just focus on the concept. If we have 100, okay, over any value of zero or any value under zero, it's going to be zero. And that's what we have here. And that's what happened when an area is not ventilated, but it is perfused, which means that the perfusion is any value, but the ventilation is always zero. And that is why we get a zero always. And this is hypoventilated. There is perfusion, but there is no ventilation to match the perfusion. And you will now ask me, what does a right to left shunt mean here? Basically, it's just, you know how this heart is on the right side, it's always deoxygenated blood, and on the left side is mostly oxygenated blood, right? So a right to left shunt is an abnormality, either in an anatomy or physiological abnormality that mixes this venous blood or deoxygenated blood with the red blood or the um, left heart blood, which is oxygenated. And remember when we talked about VQ? In this case, we don't see any ventilation at all. There is no alveoli, no air involved. And that is why V equals zero here. But there is perfusion. There is perfusion. If you think about it, there is perfusion, even though it's mixing and everything, but there is zero. Even if the perfusion was so small as in like 1, the VQ ratio is always going to be zero because the ventilation, there's zero non-existent ventilation. Now, physiologically speaking, on a separate note, what a right to left shunt does is that it just lowers the pressure of arterial oxygen. Okay. This is the result of a right to left shunt, and it makes sense when you mix for example when you have 50 cups of 100% oxygen, okay, and you have 50 cups of 0% oxygen, and you mix them, you have 100 cups, right? Cups, but 50% oxygen, you know, because they got mixed up, and this leads into a decreased pressure of arterial O2. I hope this is clear. Okay, so our last slide before our checkpoint is a thing that we already can assume, which is VQ high and VQ low. What do they both mean? Okay, very simple. We know that ventilation brings in oxygen and takes out CO2 from the arteries. And so, keeping that in mind, if we have an area that has so much ventilation but low perfusion, what do we think the blood is going to have? A lot of oxygen and low carbon dioxide. Why? Because carbon dioxide was easily let away from the blood, and the blood found so much oxygen from the surplus of air of ventilation to take it. So a higher VQ ratio means that there is increased PO2 and decreased of CO2. Okay. Now let's take the opposite of that, which is which is a low VQ ratio. There is more perfusion than there is ventilation. So we know that the blood has the carbon dioxide and the air has oxygen, and there's an exchange. So the low ventilation leads to lower O2. Very simple. And the and the high perfusion, because in a high VQ, in a low VQ ratio, we have high ventilation, we reach an increase of PCO2, and the blood was not able to get rid of it because of the hypoventilation, because there is no adequate ventilation to take away that CO2. And I hope that is clear, because this is very, very important, and it's like a core concept that you have to know by second nature. You see these disparities? Now you will tell me, oh, so the top of the lung is the best area for breathing, right? Because it has higher O2 and decreased CO2. Oh, perfect, right? Yes, but no. Why? Because where does most of the oxygen that we get into the blood come from? Paradoxically, it's in the base of the lung. And why is that? Can someone take a wild guess? I think you guys can't. So, very simply, because as we said, when we go back to this photo, there is so much oxygen. Even though that there's like relatively lower ventilation, but at least 75% of the oxygen is very well ventilated, right? So the amount of oxygen taken by the blood is larger in the base. The base takes in so much more oxygen because there's so much more perfusion. And that is why the bulk of oxygen comes from the base of the lung. Now we reached our first checkpoint. This is a chance for all of you to ask me any questions you have. You can ask me now or later, but it's just to make sure that you guys have 100% checked off everything and all the concepts we covered um, previously. Are we all good? Okay, this is a very good question. The oxygen uptake is hot. Okay, so it's either a ratio or volume or amount. Okay, think about it this way. In the top of the lung, there is a higher ratio, or in the top of the lung, the blood will contain a single unit of blood is going to contain way much more oxygen than the same exact unit in the base. However, when you go and count the total oxygen entering the body from the areas in the base of the lung and compare it with the amount of total oxygen entering the body from the top of the lung, you will find that there is more oxygen entering from the base of the lung. And again, this is a very normal thing and it's very much to be expected because we know that the base of the lung gets a lot of perfusion. And also, even if it's not in the same ratio, we get more ventilation. So more perfusion, more ventilation means that there is more amounts of blood getting ventilated. I hope that is clear. You can confirm if you got it, or I can repeat it again. Okay, great. Um, I hope nobody else has a question. Since you don't, I have a question for you. And I want someone to answer this for me. I'm just gonna read it out. So regional differences in ventilation perfusion ratios affect gas tensions in pulmonary blood. We're basically saying different areas of the lung has different ratios, and that's why we have different pressures of different gases. What regional gas tensions will be observed in the blood leaving alveolar capillaries of healthy standing individual? We have a healthy individual, nothing wrong with them. Which region has the correct CO2 tension and O2 tension with it? We're talking about arterial blood, by the way, like capillaries, blood. Oh, so we have answers. Um, Great job. It's number three. That I do recognize that this might be a confusing question, but it actually tackles if you got the core concept or not. Now, why is it three? As we said, O2 tension, there is more ventilation at the apex, right? So that means the same unit of blood is getting pumped with oxygen so much. And that is why the O2 tension in the blood in the top of the lung is highest at the apex. And relatively, because a VQ ratio, it always goes back to VQ ratio. Why is CO2 lowest at the apex? Because there is so much at the no because at the apex we have so much ventilation and decreased perfusion. And the decreased perfusion means that there is less venous blood that is rich with carbon dioxide reaching the top um, areas of the lung. Because there is less venous blood reaching there, it means that there is less CO2 tension. Okay? Do we have any questions? Okay. So I would suspect that we don't, which is a bit sus. You guys, I oh, there is someone that has a question. Can you repeat why CO2 is low at the apex? Okay. Uh, so what does blood do? Blood takes CO2, venous blood at the apex takes CO2 to the alveoli to get rid of it, right? So we have 1 unit of blood versus, for example, these are just, by the way, hypothetical situations. 3 units of air. So this unit of blood is able to get rid of the carbon dioxide because this is full of CO2, okay? It has so many like air options to get rid of CO2. And that is why it leaves the lung. Okay, these are the lungs, by the way, guys. Don't mind the drawing. It leaves the lung having gotten rid of CO2 because of the hyperventilation. There is so much air that it's really taking in O2 and freely, very freely getting rid of CO2. Okay. If you compare it at the base, you have, for examples, in like you have 2 units of oxygen blood for 1 unit of air. And so only one of them is going to be able to get rid of the carbon dioxide they have. And by the way, this is true for the base. For the base, the PO2 tension is the lowest at the base, and CO2, oh, sorry. The O2 tension is the lowest at the base, and CO2 tension is the highest at the base because there is no. So the key concept here is that the ventilation takes oxygen, carbon dioxide, and gives oxygen. High ventilation areas relative to blood means that this blood is freely getting rid of carbon dioxide and freely getting O2. And that is why it's highest at the apex, because the highest ventilation perfusion ratio is high in the apex, and CO2 is easily getting rid of at the apex, so that's why it's lowest, because it gets rid of it very easily. And I hope that since at the base there is more O2 available, the vessels will get rid of CO2 to get the O2, and the opposite true for the base. Now, chemically, it's not related. like CO2 dissociation, O2 association is not related. But if that helps your understanding, then you kind of can say that, you know. The core concept here is that the ventilation is what gives us oxygen and takes from us CO2. So higher ventilation means more O2 and decreased CO2 from the blood because we gave the CO2 away. Decreased ventilation means that we have lower oxygen because ventilation is what gives us oxygen, and increased CO2 because we weren't able to give so much of the carbon dioxide because the air can only hold so much, you know? Okay. So we can take out a lot of CO2 out of the blood and onto at the apex, but base we have higher total oxygen taken in, the high CO2 total getting out. Yes. And the reasoning to the second the second sentence in your question is again blood perfusion. The amount, okay, just say amount equals to amount. So why we have a lot of oxygen in the base coming in as an amount, because we have a lot of amount of blood that is getting ventilated, even though not at the same efficiency or ratio as the apex. Okay, so the base is only about amount and the apex is more about high ventilation. So we have basically paradise. We can take as many O2 as we want and dump as many CO2 as we want. I hope this is clear. Okay. Um, any more questions before we proceed? Okay. Okay. This is where it gets a bit more confusing, but we already explained it, and I promise. Let's take this step by step. We'll start from here, okay? We know that relatively at the top of the lung, we have more ventilation or higher VQ mismatch, VQ ratio, higher ventilation than there is perfusion. So that means, as we said, hyperventilated, right? Remember this figure. Up, hyperventilated because we have high ventilation relatively. So far, it's all everything we know. So because it's hyperventilated, there is more air. Okay? More air in hyperventilated areas. What happens? It means that these areas are the areas that contributes more to mixed alveolar gas. I'm sure you guys are lost. Okay. We are now mentioning something called alveolar arterial difference. It's basically the difference between the mixed gas, the quantities of CO2 and O2 in the mixed gas on exhalation after everything, like after the whole lung, okay? The whole lung has taken its ventilation perfusion, and we exhale this mixed air from the top, base, bottom, middle, everything. And we're measuring the mixed arterial values as well. After the whole top, bottom, middle, everything finished and exited the lung and went back to the heart. So here we're talking about mixed values type. Let's go back to the drawing I have for you guys. So because it's hyperventilated, you can say that more air is concentrated there, or air, because it's hyperventilated, you have to link it like that because it's hyperventilated, it's more related to the air, and therefore it contributes more to the gas. And if you want to contrast it for now, here, hypoventilated because of the bottom, more blood in the bottom, so it contributes more to the blood, okay? But keep that like separate, okay? So again, hyperventilated areas, they contribute more to the gas. to the mixed alveolar gas. What? How do we know that? Because the PO2, the mixed gas that we exhale after we respire and we exhale, okay, this is a mixture of all the alveoli. And so that if we want to analyze that gas, we will see that the oxygen pressure in that gas lies closer to the values at these places at the top. Okay? It's written here. PO2 of mixed alveolar gas lies closer to the PO2 of the hyperventilated regions. Because again, hyperventilated means more air, it takes a bigger chunk of it, and there is a lot of oxygen there. Tamam? Let's go to the other side of the story, which is the hypoventilated regions. We know that hypoventilated regions are at the bottom because they have more perfusion um, than they have ventilation. By the way, we are depending on this diagram. Here we have more ventilation, okay? This is the place that we have more ventilation than perfusion. And at the bottom, we have more perfusion than ventilation. And that's why we're saying, oh, bottom, more perfusion, and top, more ventilation. Even though like the arrows are increasing towards the down and everything. We're all talking about ratios, okay? Remember, it's all about ventilation, perfusion ratios. Okay, so the hypoventilated regions are on the bottom because there is more blood, more perfusion than there is air, relatively. So what does that mean? Because there is more blood at the bottom hypoventilated areas contribute more to the mixed arterial blood. Because, okay, so here we have more air, so it contributes more to the gas. But here we have hypoventilated, more blood contributes more to the arterial blood values. And what is the final result? The final result is that the PO2 of mixed arterial blood after it leaves the lung, mixed arterial, yani from the top and bottom and everywhere in the lung, lies closer to the hypoventilated regions. Again, how do you memorize it? Is because arterial contains blood. Where is the part of the lung that has the most blood? Bottom. And that's why the hypoventilated or the bottom areas of the lung are the ones that contribute most to arterial blood mixtures. And if you see this difference, we have two PO2. We have the first, we have the first value of PO2 and the second one. The first one is for arterial and the second one is for alveolar. You see how we're going to our definition? It's alveolar minus arterial difference. Tamam? Do we have any questions? Because I do believe it's a bit dense, that this slide is a bit confusing. Okay. Just to comment on that, alveolar arterial difference is a value that depends hugely on VQ variations. Because if we have a high VQ, if we have a high VQ, it means that the alveolar, okay, how do we phrase that? It means that the alveolar O2 is decreased. You know why? Because if we have high ventilation and perfusion and everything, we decrease the alveolar gas because we took this O2, we took the oxygen already outside. And that is why we have a smaller one. And what does a smaller PaO2 give us? A smaller difference. And the smaller difference is perfect for us. Okay, let's take the other case. We have a VQ that is smaller. So high perfusion, low ventilation. What do we have? We have a greater arterial difference. Why? Because we have so much perfusion, so we took so much oxygen. And so therefore we have a greater arterial PaO2 value. And what does subtracting from from an increased value give us? A smaller difference. You see how there's this whole dynamic. You have to practice with it. You have to like write it down between you and yourself to understand, to actually like make it second nature for you. Okay? But يعني it's not gonna be tested on it like this. It's just that it's just more of like to conceptualize it for you. You just have to know that it's affected by VQ variations. In the slides, it's written as a normal value has to be between 3 and 10, but I have never seen that it was mentioned in the exam. But always remember, please, alveolar arterial difference always depend on the mixed values. Mixed alveolar after expiration and mixed values after arterial differences. Okay? Um, mhm. Okay. We also have a difference in carbon dioxide because, again, different compartments, different dynamics. Okay. It's also affected by VQ variation, but it's not as important. Why is it not as important? I'm going to answer you. Why is it not as important and we don't study it so much in detail and we don't need to know it? Because of two reasons. The first reason is this graph. But we have the same amount of blood and we infused these two amounts of blood with the same exact amount of O2 and the same exact amount of CO2. طيب? What is the difference? We found that when infusing this much CO2, it only changed this much pressure of CO2 in this blood. However, when we put this much, like they're relatively the same amounts of oxygen and CO2, it changed dramatically. As you can see, only 5 change here and 60 change here, which is crazy. And this is the reason why the arterial alveolar difference between alveoli and arteries uh, doesn't matter as much for carbon dioxide because the curve is so steep that we have only a smaller difference, but in oxygen we have a bigger difference. So the difference is like more significant, you know. The effect in the pressure of O2 is way bigger than the effect of PCO2. So that's why we don't take the alveolar arterial difference in carbon dioxide as a parameter. The second thing is that, and you have to keep this in mind for the second lecture, okay? The PCO2 is a very strong stimulus for breathing. If we have a slight increase in PaCO2 in our blood, our reflex mechanisms are gonna force you to breathe faster to get rid of the CO2 quicker. And so that it's very much easily solvable because this is how we were made, and the reflex directly induces ventilation to get rid of this extra CO2. These are two reasons why CO2 alveolar arterial difference are not important. I might have went into so much detail, but يعني you guys have to know why what this graph means. They're not going to ask you why is it not important, but I'm pretty sure that this concept is very important for you to understand. But I think this is one of the very okay. This is we have approached kind of the end of our lecture. Um, so is this graph or this diagram you have seen it before. Remember that hypoxia causes vasoconstriction and hypocapnia causes bronchoconstriction. And I'll make it make sense to you. Okay. So in the first example over here, we have a bronchi or an alveolar space, okay, that has very low CO2. What does this mean? Is that يعني احنا we breathed, but there is no adequate blood flow to that specific alveoli that's giving it CO2. Because of the decreased blood flow, the CO2 is decreased in that alveoli. تمام? And what does our very smart body do? It bronchoconstricts to divert this air that's going to a يعني not so productive region because there is very small blood flow, to divert this air into somewhere with higher blood flow, because that makes us have a more normal VQ ratio, which is the best. تمام? Because here we have a lot of ventilation and very small perfusion. How do we solve it? We take this ventilation somewhere with better perfusion. But the second case. The second case is that when we have hypoxic vasoconstriction. Remember that all of these are cases inside the air, not in the vessels. Actually, no, yeah. Hypocapnic is in the vessel, in the air, but hypoxia happens in the in vessels. And so therefore, what hypoxia happens in the vessels, it causes vessels to contract, but when hypocapnia happens in the air, it causes the alveoli or the bronchi to constrict, I mean. Okay. So what does hypoxic vasoconstriction mean? It means that when the blood has low oxygen, it will decrease. I'm sure you can tell me why. It will vasoconstrict because there is low oxygen. Why? Because it thinks that this bronchi or this alveoli is not giving us enough oxygen. So let me constrict and not give it so much blood and so much attention, and take the attention or the more like the bulk of the blood somewhere where we have actually good ventilation. So in low ventilation, high perfusion, we have hypoxia in the vessels that induces the vessels to contract or constrict, to divert, okay, to shift the blood somewhere with more oxygen, which is more ventilated. Do we have any questions? This is our second checkpoint. It got so hard, the lecture got so hard suddenly, but I hope you guys caught up. If we have any questions, please type them in the chat box. Because by the way, we're gonna expand on all of these concepts right now, and you have to make sure you have a solid base. But there appears to be no questions. But I want you to read this question. You're not gonna answer it now because we still haven't understood. But this question actually came in our year, and we have to know how to understand and solve these questions. It gives us how much PO2 they have and how much PCO2 and the alveolar arterial difference, how much, and they expect us to know what is the problem. Like, this is, you know how Dr. Paul says, a picture worth 1,000 words? This is a picture that's worth 1,000 words. A patient comes with hypoxemia. And this is, by the way, the differential diagnosis. Like in your future, this is the way you're gonna tackle every single patient or case. By differentials, excluding and ruling out some stuff. But by the way, I guarantee like 100% a question will come from this. So it's very important. If you want, take a screenshot. You can see it from my slides. It's all yours, okay? So a patient comes with hypoxemia. We know that there are 5 causes of hypoxemia from the last lecture, last past session. It's either hypoventilation, or high altitude, which means that the air that we breathe doesn't have enough oxygen, or there is a right to left shunt, as we discussed in the beginning, and there is the fusion problem, or a VQ mismatch. How do we reach what conclusion? The first thing we do is Ask, how much is the PaCO2? PaCO2, 40 is normal. Lower than 40 is good. طيب, I'm gonna tell you a case and I want someone to answer me. If we have low oxygen but high carbon dioxide, what do you think the cause is? Yalla, quick, let's finish this quickly. Well, it's related to ventilation, but it's not hyperventilation. Because remember, hyperventilation gives us more O2. Then how are we gonna getting hypoxemia from hyperventilation? It's actually the opposite. In hypoventilation, we're not getting rid of the CO2, and that's why we have an increased arterial CO2, and we're not getting O2, and that's why it causes hypoxemia. تمام? So a compound decrease in oxygen and increase in CO2 means that we're not breathing adequately, and hypoventilation is the cause. تمام? And by the way, 40 millimeters of mercury is your threshold. Is this clear? Perfect. طيب, what if we have both low oxygen and low CO2? It means that we are breathing adequately. It's not hypoventilation. Okay, so we have low CO2. What does that mean? That we're breathing adequately. We're getting rid of the CO2, but we're not getting enough oxygen. What could be the cause? High altitude. Because in high altitude, there is low concentration of oxygen in the air. And so therefore, because we are ventilating perfectly, we get rid of carbon dioxide, and therefore we have low carbon dioxide amount. But we have low oxygen that is attributed to the high altitude or lower inspired O2 concentration. Is this clear? Tamam. So again, very quickly, hypoventilation, we have high O2, low O2. In all of these cases, we have low O2. If we have high carbon dioxide, it means that we are not getting enough perfusion or ventilation, معلش. If we have low CO2, it means that we are ventilating, but we can't get enough oxygen. That is attributed to the low oxygen in the environment in high altitude. Type. If both of these didn't work, we have three situations left. What are they? And we have to test them. Type. If we give 100% oxygen test, like we put them on an incubator and we give them 100% oxygen. If the hypoxemia still didn't resolve, it means that there is a right to left shunt. Why? Because the deoxygenated blood is mixing with the oxygenated blood somewhere that is not related to the lungs, as in the heart, right? So even if we give them 200% oxygen, maybe, a right to left shunt will still screw up our oxygen concentrations and lead us to hypoxemia. تمام. I hope this is clear. If after 100% oxygen is still bad, then it's a right to left shunt and it doesn't have to do anything with the lungs. But if still this didn't give us a conclusive answer, what do? We do a carbon monoxide diffusion test. A carbon dioxide diffusion test tells us how the barrier is working. Why? Because carbon oxide diffusion is 100%, which means that it strongly diffuses. There is no limitation to it. So if we give a diffusion test and the carbon monoxide is low, then we are going to conclude that there is a diffusion problem because even the carbon monoxide got affected. And this is diffusion problem applies to all, by the way, like carbon dioxide, carbon monoxide, oxygen. Okay? I think this is easy, yani. If carbon monoxide diffusion is low, then we have diffusion problems. If none of them, like, okay, carbon dioxide diffusion is good. If we gave 100% oxygen and and it got better, so it's not a right to left shunt, and it's not a diffusion problem, not hyperventilation, not a high altitude, we have nothing else than VQ mismatch. طيب. This is a very core concept, and I'm pretty sure that they will ask you about this. Now, I want someone to answer this question. We have oxygen, low arterial oxygen, and we have high PCO2. What is the reason? Guys, come on. It's hypoventilation. That is true. It's hypoventilation. Why? Because again, we have low O2 and high CO2, which means we're not breathing to get rid of the CO2 and not breathing to get more oxygen. Very simple, very easy, okay? But please engrave this in your mind and memorize it. Yani, I'm pretty sure they're gonna get you a question for like um a difficult uh like a difficult case. Okay. By the way, this table I literally stole it from Dr. Sham's slides. It's literally the same thing. طيب. Except if you try to like go through the cells and apply this logic here, it will all make sense to you. Okay, so therefore I will not spend so much time on it. تمام. But there are two things that I need to note. The first thing is here. Why do we need to be careful by infusing someone who is hypoventilating by 100% O2? You should be very careful. طيب. Because sometimes in some patients we have different receptors, different stimuli for breathing. In all humans, CO2 and oxygen, they both stimulate breathing. But sometimes there is a problem there, and it's only stimulated by oxygen, not by carbon dioxide. By the way, don't get confused by this very early because we will explain it later in detail in the next lecture and the control of breathing. But just be careful when infusing a hypoventilating person with 100% oxygen, because if their CO2 stimulus is not working, and so they depend on the low oxygen. If you give them 100% oxygen and the oxygen is good, they will stop breathing. They will stop breathing at all, and it's going to be a problem. But don't concern yourself so much about this for now. Okay. Now we go to the control of breathing, which is the second lecture. I just want to make sure we don't have any questions for the first lecture. I know. Do you guys want to take a break or? The second part of the lecture is not going to take long, by the way. It's very simple. It's like 5 pieces of information that we need to know. Okay, perfect. We said we want to complete. Control of breathing. Again, I tried to make it as concise and simple as possible. It's quite complicated, but inshallah it will be very easy. Okay. Yeah. Control of breathing. This is the rhythm generator, as we can see. The rhythm generator is a part of our brain that controls the breathing or the rhythm of breathing. We have 3 parts of it, and this is very important to memorize. Okay. We have a pneumotaxic center. We have ventral respiratory group. You can see here the name, okay? And we have dorsal respiratory group. Let's take this as a story. We have inputs from systems into our brain, right? And we call them afferents. And so all inputs go to the dorsal respiratory group. As we can see, all inputs go to the dorsal respiratory group. And this dorsal respiratory group takes it to the ventral respiratory group, which is today's main character. It's very important. The ventral respiratory group is crucial. Now you have to understand that the pneumotaxic center is just the off switch. It's just an off switch that wants to close breathing. خلاص. They don't want to breathe. Pneumotaxic center. Okay. So just at this point, it's just pure memorization, nothing so much to understand other than that the inputs from the system goes to the dorsal respiratory group, which takes it to the ventral respiratory group, gets it processed, and then the efferents come out of the ventral respiratory group. What does the pneumotaxic center do? It just wants to switch it off and stop breathing. Okay. Again, rhythm generator, ventral respiratory group contains both signals to initiate inspiration and initiate expiration, both. Okay. It's the main character for today. It generates the rhythm. It controls the rate that we breathe. It can even fire without afferent input. Even if we're not stimulated to breathe, it keeps on firing automatically. Like for this inspiratory ramp, what is an inspiratory ramp for this third point? You saw it here as well, but what is it? It's basically that the ventral respiratory group sends nerves. This is, by the way, nerve stimuli. Like it sends to the muscles of the respiratory system to increase. These are increased firings. Firing one, firing two. You see how they get stronger and stronger and stronger until they reach a peak after 2 seconds and they suddenly fall. Suddenly. And this is what we call a respiratory ramp, where it keeps on firing increasingly for the 2 seconds, and then in the beginning of the third second, it falls, and we stay expirating for 3 seconds. If we want to correlate that to the breathing, we know that we breathe subconsciously for 2 seconds, and then suddenly we stop breathing and we let the passive recoil expirate all the air from the lung. Like, it's very important to know that the passive recoil is what makes the expiration happen during this like decreased firing period. Okay, so what causes this sudden fall, skydive from up to down? Both the ventral respiratory group, as we said, it has signals to initiate expiration, and it has signals to initiate inspiration, both. So the first thing that causes this fall is the ventral respiratory group. What happened? Okay, is the ventral respiratory group. The second one is our playboy for today, as we said. The pneumotaxic center only wants to switch it off. So this is where he comes into and plays with us and inhibits our breathing. Okay, this is what a respiratory ramp is. Right. Sometimes when we have issues with our lungs and the passive recoil and normal respiratory muscles are not working, the ventral respiratory group, which is our main character for today, forces these muscles to these external muscles or accessory expiratory muscles to go and expire it. Okay. And the last thing that's important to note, by the way, everything important, I put it in bold or underlined, that the ventral respiratory group increases the rhythm or the activity of it with sympathetic stimulation. And it actually makes sense because, you know, when you're running from a dinosaur, as Dr. Vlad says, you want to breathe a lot. I hope this is clear. Now, so what we talked about regulation, right? There is a slide that's missing. Hold on. Oopsies. Just stay with me for a bit. We can cut it on YouTube. Keep it. طيب. طيب, we said that there are afferents to the dorsal respiratory group. What are these afferents? They include two types of receptors, mechanoreceptors or chemoreceptors. Please, what is this? Okay. Um, so it's either mechanoreceptors or chemoreceptors. The mechanoreceptors are either in the lung and or in the muscles, or the chemoreceptors can be in the peripheral or central nervous system. They sense chemical changes. Mechanoreceptors sense distension and stretch. Like, this is a very important slide. To be honest, this is just pure memorization. They will ask you about this 100%. Okay, I saw a question about this slide every single past paper I read. Okay, there are three types of mechanoreceptors. The first one is slow mechanoreceptors. All of these are in the lung, okay? These are in the lung, not in the muscles. Um, so about these slow mechanoreceptors, they are myelinated. Okay, they are initiated or they are stimulated when you are inspiring. They sense inspiration, distension. They sense when you hold your breath, and they sense when you deflate. When you deflate so much, like lower than the functional residual capacity, and you actually like you want to force your lungs out. You know, they sense these three situations. Why? Because they send signals to the dorsal and then ventral to stop these actions. If you distend without inhibitory action, then your lungs are just going to pop out. If you hold your breath and don't change that, you're going to die. If you deflate so much smaller than the functional residual capacity, then that's also a very bad situation. So what does it do? Again, it terminates inspiration when you're over distenting, and it terminates large expiration in this case. طيب. So this is just pure memorization and understanding, like basic understanding. It terminates both inspiration and expiration. So less of the slowly adapting pulmonary stretch receptors, or what they call Herring-Brewer. Okay, by the way, they're gonna get both names. They can get both names. Okay, there are rapidly ones. Rapidly ones are very easy to understand because if you have an irritant, like a chemical, you inhale the chemical, or an allergen or anything that irritates your lung, it will induce you to cough. In distension and irritants, it will cause you to cough and just emit this irritant that you took in. Okay, so this is why it's called rapid. Rapid because it rapidly responds to irritants through cough and gasping. Okay, tamam. And this is very important because sometimes in post lung transplant, these receptors or like nerves are not transplanted or like connected. And that's why you find poor cough or even sometimes absent cough. And this came in as a question, by the way. Which receptors function is suppressed in lung transplant, leading to the loss of cough reflex? You have to know that it's the rapidly adapting one. Okay. The last one is C fibers or J receptors, sorry. Now, they are important to note that these are unmyelinated. This is the special one, okay? They're unmyelinated. They sense edema and congestion through interstitial fluid, and they sense pulmonary embolism. And we know embolism is like a clot that goes and like blocks the lung. But this is not very important at your stage. And when you have congestion or edema or even embolism, you have rapid shallow breathing and you have cardiovascular depression. You tell the heart to stop, like relax. We can't deal with more blood because we have a situation. تمام. Uh, so remember that pulmonary edema and pulmonary embolism, which is like a plaque or a clot, okay, that goes and blocks blood from the lungs. Uh, they are fired through C fiber or J receptors. Okay, these are like the special characteristics. The last point is for the special characteristics of each. This is what we call lung stretch reflex. We have the rhythm generator stimulating the inspiratory muscles. It keeps on distending, distending, distending. And the more it distends, the higher a single mechanoreceptor tells the brain, oh, look, we're distending, so please shut us off. Until you distend so much, and خلاص, your brain decides to stop. Okay? Now, my trick question for you is, which of these do you think, which of these receptors do you think are here? Let's see who's following. Oh, perfect. Oh, beautiful. You are following. You basically got the concept very well. So props to you. Okay. Now we have a different type of mechanoreceptors as in the muscles. Now this is not very high yield. The details aren't very high yield, but it's just for you to get the concept, okay? So we have gamma spindles and alpha spindles, okay? So gamma spindles are in the intercostals and diaphragm. These are respiratory muscles, as we said, okay? They sense distension, right? So gamma are the sensing, but gamma and alpha together are the ones that execute the contraction order. Because if we have nerve stimuli, we execute it, okay? Remember, gamma is the only one that senses. Like, if we have a contraction order, we have two choices. It's either contraction happens and no problem, it's all good, or we have that the contraction order does not produce adequate shortening. It's either when your muscles aren't working well, when there's an obstruction, a lot of problems. But when we have an order and it's not matching to appropriate distension of the lung, gamma gamma spindles will sense that. And what does it do? Gamma goes and tells alpha, we need more stimulation, fire more. As the last chance, fire more. And alpha fires more to increase the stimulus or increase the force of contraction. What happens? Either two choices. It's either that we go back to normal and it's all good, or the issue still persists. There's still no distension that's appropriate to the command that we're giving. If that happens, the inspiration stops. They just burn everything. They say, خلاص, I'm not doing this anymore. It stops. And therefore, the inspiration is suspended early and expiration starts. And that's why sometimes in muscle paralysis or sometimes in lung obstruction, you breathe very shallow and very quickly. Why? Because أول شيء, the first thing is that they give a contraction order, but it doesn't give the appropriate distension. They give you a second chance, alpha fires, but it's still no use. So that's why they suspend everything. Okay, tamam. So this is a important clinical note that restrictive disease are in stiff lungs. Stiff lungs are not responsive, not compliant, and we all know that what is a restrictive disease. It's been emphasized so much by Dr. Shams Hashim. So in stiff lungs, as we said, it's not appropriate distension, and that's why there is no use, so it suspends early. Okay, and therefore we have small and fast breaths. تمام. But in obstructive disease like emphysema or COPD, the lungs fill slowly, 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 slowly. So the muscles keep pulling because the gamma is not sensing a very strong change, because, as we know, these receptors are also there. Everything is just interconnected. If you have less contraction or more contraction than what you wanted. Here we have less contraction than what we wanted because the lungs fill slowly is super, super, super compliant. And therefore we have big and shallow breaths, big and slow breaths because the gamma doesn't inhibit it very early or normally. Okay? I get that obstructive is a bit more confusing, but I believe that restrictive diseases in this context is going to be more high yield. Like the second type of receptors, let's do this quickly, inshallah. There are chemoreceptors. Chemoreceptors, as we know, they're either peripheral or central. تمام? Uh, Okay, so what do central chemoreceptors, what is the mechanism? You have to know that I just put this because so that you can visualize, but you don't have to know or memorize everything here. Just know that rostral, intermediate, and caudal in case they bring it. But I'm doubtful, Salah. Okay, so when you have increased arterial pressure of CO2, increased CO2, it means that we need to breathe to get rid of it. How does the body do that? It senses it through a decrease in pH because we know that CO2 is like increases the decreases the increases the acidity and decreases the pH. And these receptors, which are the central chemoreceptors, sense this change in CSF, cerebral spinal fluid, pH. And the minute it changes, it stimulates breathing. Again, this is very simple, very easy. Increased PCO2, decreased pH or more acidity, and therefore stimulated breathing. طيب, you tell me that acidity is always changing through buffers and everything with all the systems that we have in the body. Why isn't it all changing ventilation? I would respond to you by saying that I respond to you by three letters. BBB, which is the blood-brain barrier. تمام? The ions do not readily diffuse into the CSF through the BBB. So it's kind of like a protective thing. So this issue, or like pH changes, CO2, near the spinal cord or the brain, is just exclusive to the carbon dioxide. A second type of chemoreceptors that we have is peripheral. These peripheral chemoreceptors, we have both aortic and carotid, but to be honest, carotid is just more, just memorize it as carotid because aortic don't work in humans that much, okay? Now, carotid takes through glossopharyngeal nerve. This one you have to know. You have to know that carotid bodies are peripheral chemoreceptors and they carry their efferents through the glossopharyngeal nerve. What is the threshold? What is the threshold of these peripheral chemoreceptors? When do they start firing? Now you have to memorize it that it's either when arterial pressure of O2 is less than 80 or the arterial pressure of CO2 is more than 40. Remember, 40 is the normal. And when pH is less than 7.4. What do we conclude from this? Is that PO2 or oxygen only induces peripheral chemoreceptors, but carbon dioxide levels induce both central and peripheral. تمام? Um, Also, it's just mentioned in the slides that type 1 cell is the receptor. Okay, the two slides, they put it in whole paragraphs. The only thing you need to know out of it is that type 1 cell is the receptor in these carotid bodies. Okay, and the mechanism is still unclear. It's under research, so I'm pretty sure it's not going to appear in the exam. Inshallah, inshallah. Okay. طيب. We have the last three slides. First of all, I think we have gone so far without a checkpoint. So, uh, what did you mean by the slow? I'm sorry, I didn't take notice to the comment section. Was the issue resolved, or do you still have the question? Oh, okay, okay, okay. But I didn't know why the question marks. Okay. Yes, it was the slow one, as we all know. Like now you're probably thinking, what is going on? It's way more simpler than what you think. Like, let's start bit by bit. We know that decreased PaO2 induces higher ventilation, right? So what does higher ventilation do? It decreases CO2, right? Because we're ventilating more, we're getting rid of CO2. And this is what's written here. The more we ventilate, the more we get rid of carbon dioxide. And because we have decreased carbon dioxide, and we know that carbon dioxide, memorize this very well, carbon dioxide is the most potent effector on ventilation. Okay, it's the most important one, like out of the gases and ions. طيب? Because we have decreased carbon dioxide, we have decreased ventilation. So this response to oxygen is kind of masked because the effect of carbon dioxide is way higher than the body responds to levels of oxygen. And this is what they're saying in this graph. I don't know how this graph will appear, but it's important to note that the key from both of these graphs is that carbon dioxide is the most important one. Why? Because in an experiment, they stabilized carbon dioxide. They kept it at 40. طيب? And you see how the ventilation kept going up because it was not masked by the decreasing levels of carbon dioxide by hyperventilating, because they kept on leaving the carbon dioxide at like a constant level. But in normal cases is the red line. Red line in normal cases, we have decreased oxygen, higher ventilation. Therefore, in higher ventilation, we have decreased carbon dioxide. And this masking effect of carbon dioxide being more important than oxygen, it lowers this curve. And I hope this is clear. It's written here. Because reflex extra breathing decreases PaCO2, which damps the drive. It slows it down. So the real response is smaller or like shifted downwards than the CO2 constant ideal one. And it's exactly the same here in pH, because a decrease in pH increases breathing, but the increase in breathing decreases PaCO2. Therefore, we have suppressed breathing reflex, and we have this. But when they kept it constant, it kept on going up and not getting masked. Is this clear? So what do we conclude from these two experiments? Is that the ventilation responses are higher if PaCO2 is kept constant. صح? We said that. It's very obvious, okay? Which means that PaCO2 is the main character. It's the most important stimulus for breathing. How? As we said, that chemoreceptors are affected by CO2 and not affected by O2 at all. But CO2 also acts on peripheral and central. So it has stronger effect. But PO2 only affects the peripheral chemoreceptors. It's important to note that in central chemoreceptors, only pH and hydrogen levels are like the messenger of how the body knows that we have increased CO2. But in peripheral chemoreceptors, CO2 can act directly. Okay, يعني this is more of memorizing. It gets a bit confusing, but just know this one works on both. But in peripheral chemoreceptor, PaCO2 acts directly. However, in central chemoreceptor, it acts through hydrogen levels, and PO2 only acts on peripheral chemoreceptors directly. Okay. And we have a checkpoint. Do you have any questions for me? I think not. Oh, it's either you guys are not following up or I'm actually a good explainer. Okay, I hope. Okay, so I have a question for you guys. Peripheral chemoreceptors are stimulated to the greatest extent by either hypoxic hypercapnia or hypoxic hypocapnia or hypercapnic hypoxia or hypercapnic hyperoxia or isocapnic hypoxia. Go through each option. Which one do you think? See, perfect. Wow. Uh, really great job. And if anybody is not getting it, please tell me then. I will explain later. Okay, last two slides. It's been a ride. Okay, so there are two types of responses to two different situations in the blood. We have hypercapnia or increased carbon dioxide in the blood, or we have hypoxia, which is decreased carbon dioxide in the blood. So it's important to differentiate the acute versus chronic response to each of the situations. And let me tell you the story. In hypercapnia, if you get a hypercapnia or increased CO2, it goes to the blood at central chemoreceptors, and all this party happens where we get increased ventilation. So at the beginning, because CO2 is a very strong stimulus, we have a huge breathing drive in acute response. But in chronic, the kidneys kind of on chronic, like we're talking about weeks of hypercapnia, days, weeks, or even sometimes months of hypercapnia. The kidneys need to adapt to these different pH levels. We're talking about the blood, huh? Remember, the blood-brain barrier does not allow ions freely floating in the blood to cross into the CSF. So we're talking here that the kidneys start secreting bicarbonates to decrease or to decrease the acidity and raise the pH levels um, to normalize them. So therefore, the central CO2 drive decreases because the kidney compensates through the regulation of blood pH and everything. Okay. Like chronic kidneys start working, and so we have decreased breathing. But in hypoxia, in the acute response, as we know that hypoxia only acts on peripheral chemoreceptors. So therefore, the response is going to be a bit weaker. So through the carotid bodies, we start hyperventilating for a bit. But remember when we start ventilating, CO2 decreases, and so therefore the response is masked and we start slowing ventilation. And that is why we have a brief, very brief boost in breathing in acute hypoxia. But as we continue to be hypoxic for days, weeks, or months, the kidneys also intervene to to deal with the alkalosis and the pH levels imbalance here. So therefore, kidneys are involved in chronic both situations. Okay? So when the kidneys step in chronic responses in hypoxia, the blood pH levels are regulated, and so therefore we get unmasked or fully expressed hypoxic stimulus. It's not masked by carbon dioxide because the kidneys have يعني, made up for it. And so therefore we have sustained increased ventilation. I hope this is clear. I do agree that it's kind of confusing, but you have to take your time with it, memorize it. It's like a story, it makes sense. And this, by the way, the chronic hypoxia is in altitude acclimatization. And I was watching a documentary where people who want to travel and like go to the peak of Everest, they have to stay at base camp for 2 to 3 weeks just to get used to the decreased oxygen in the air because of high altitudes. And this is how it happens. It's very interesting. Remember when we said we had to be careful when infusing 100% oxygen on um, um, in hypoventilating patients? This is why. Because sometimes when the response for hypercapnia is dull, it doesn't work. In patients that lean more on hypoxic drive, يعني the response to carbon dioxide doesn't work. So the only thing that we respond to is the decrease in oxygen. So when we give them 100% oxygen, we 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 trick the receptors into thinking, okay, we're good. We're breathing again and we're good, whatever. So we decrease the firing of the reflexes, we decrease the ventilation drive, and so they stop breathing at all. So that's why we need to give them 100% oxygen, but be very careful with it. The last slide, this is, I don't believe this is very high yield. It's just very simple. Very, very simple. What are the stimuli for ventilation? We know that out of the ions and chemical compounds, it's carbon dioxide. From here, lowest to strongest, okay? But what is stronger than carbon dioxide is exercise. How? We're gonna explain here. But MVV, which is the maximum voluntary ventilation, is when you ask someone to breathe as quickly and as deeply as they can. This is, by the way, I saw a past question on this. What is the strongest stimuli for ventilation ever? It's MVV, not PCAO2, PaCO2, okay? It's MVV, or maximum voluntary ventilation type. Why does exercise give us a higher ventilation? First, because of the sympathetic simulation. Second, because the working muscles, the mechanoreceptors and working muscles go and tell the cerebral cortex or the rhythm generator, okay, look, we're exercising, please start breathing because we're about to go mad. And it goes to the rhythm generator uh, to um, to uh, to induce respiratory muscles to start breathing. Okay. But take notice that it can either be directly to the rhythm generator or to the cerebral cortex, and then the cerebral cortex takes the sensory and takes them back here to the rhythm generator. The cortex and the generator are different things. The cortex takes the signals, some of the signals, and also induces it. So what induces the rhythm generator? Both the mechanoreceptor through direct stimulation from the muscles, or the cortex efferent stimulation to the rhythm generator. Okay, so normally we have ventilation that leads to carbon dioxide changes to, because when you exercise, you have increased carbon dioxide, right? And in normal response, the ventilation increase it matches this increase in carbon dioxide levels. But sometimes in extreme exercise, this is important, okay? Sometimes in extreme exercise, it's out of control. Why? Because in extreme exercise, we have lactic acid. Lactic acid means decreased pH. Decreased pH means we have um, high drive to breathe, as we see here, okay? Um, and therefore, we have hyperventilation and lactic acidosis. Very simple, right? Okay, do we have any questions so far? I think that concludes 2 lectures. We took around an hour and a half. I hope I did my best to clear all of this up. If you have any notes, any questions, please don't hesitate to contact me, okay? For now, the people with us on Zoom, please ask me any questions you have before we go to the quiz. By the way, the quiz is all about questions that came in the past papers as well. Again. Do we have any questions? Should we go directly to? Okay. It's only like three questions, so it's gonna take 3 minutes. I want you guys' attention right now. Okay, so we have increased ventilation either voluntary or in hypoxia, hypercapnia, or exercise, and all of these. Okay, so which of the following is capable of producing the greatest ventilation? Perfect. Okay, we have some bright minds with us today. It is the voluntary effect. Perfect. Because again, go check this voluntary effect. Okay, so which of the following is responsible for terminating inhalation and initiating exhalation? Wow. Okay, okay. Um, you guys are good, are making me happy that the message has reached. Okay, so VAQ mismatch is compensated by local reflexes. What are those reflexes? You remember that figure of the two bronchi and two arteries? Okay, that is also correct. C. Remember, it's always constriction, and in PO2, because the oxygen has to be in the blood, so it's vasal, and it's again, it's also always constriction, and because CO2 is the it should be in the air, and that therefore it's the bronchoconstriction. Okay. Um, Great job, guys. Thank you for keeping up with me. I really enjoyed teaching this lecture because last year a lot of my batchmates said it was difficult, but I actually enjoyed it because, pulmonary physiology is really fun. When you're really intrigued about something, you enjoy studying it. And I did my best to simplify things for you. I hope you didn't find any issues with it. Please do contact me. These are my details. Finally, we're at the last slide. Thank you for keeping up with us. And please scan the QR code. And again, don't hesitate to contact me. I'd be very happy to help. Good night.